All right. Thanks everyone for coming, and thanks to the Wellness House for hosting this event. I'm Shilajit Kundu. I'm a urologic oncologist at Northwestern. It's easy to have this discussion with three urologists. I'm not going to get much flack because we're generally all on the same page. I must say, Nathaniel, I came for the Zumba class this morning, so I'm a little bit disappointed. I guess I'm talking. So anyway. I did change my talk a little bit. So initially, as I was putting this together, you know, we kind of get into this doctor's talk, and I was putting together a video on a live surgery I'd done, and I was doing it earlier this week, and I had emailed Nathaniel about it, and my 10-year-old son walks behind me, and he's like, "Dad, that's gross." And I thought, yeah, it probably is. So I took that out, and I'm going to keep it simple. I'm going to tell you a little bit about what we do, what we think about as urologists when we talk about prostate cancer surgery. So my job is a little bit easier because I'm not going to be talking so much about should we be diagnosing you. I'm going to be telling you about what we think about, what we all do when we do prostate cancer surgery, hopefully give you a little better understanding of what we do, why we do it, what are the goals of surgery, and what are the problems that can happen from it. So, you know, we kind of went over this. As people get older, they have a higher risk of prostate cancer. The question is, the lifetime risk of dying of prostate cancer in this country is about 3%. Now, a lot more men are diagnosed with prostate cancer. That doesn't mean they're going to die of prostate cancer. So, as Dr. Patel said very well, we need to be a little bit smarter in terms of figuring out who needs to be diagnosed. So we're working on that. But the question is, we still do PSA testing because, again, a lot of men are still diagnosed with prostate cancer. The good news is that most men, if you're diagnosed, are diagnosed at a localized stage. That means the cancer has not spread from the prostate to a different organ. So we say that's good news because it gives us an opportunity to cure the patient through either radiation or surgery or perhaps just watching it. But, you know, about 5% of men will have tumor that has spread beyond the prostate by the time that they're diagnosed. So the question is, right now we're trying to focus our efforts on, rightfully so, on the patients who need treatment, and how can we avoid treatment for patients who need it, who don't need it, and do better for patients who do. So does everybody here know what Gleason score is? I mean, I assume that it's somewhat of an educated crowd, but in terms of prostate cancer, otherwise you wouldn't be here, I think. So Gleason is the pathologist who looked at a bunch of pathology slides, looked at a bunch of prostate cancer, and he said, I'm going to give it a grade, 1 through 5. And so we usually don't call 1 and 2 anymore, but you're looking at a 3, 4, and 5. And you add up the two most common types, and you're given a number. So generally, the patients who we recommend treatment, again, these are globalizations, generalizations, and you can't apply that to everybody. The most common is 3. And if you have a 3 and a 3, or 6, you may not need to be treatment, may not need treatment. And I'm not going to go into that. Dr. Patel talked about that nicely. But if you have a 4 or a 5, and we think you're going to live more than 10 years, then you should consider treatment. Again, consider. It's a discussion to have between you and your physician. The other thing is if you have more than a certain amount. I say it's if you're doing a biopsy and your prostate's the size of a plum, and you have a little BB-sized tumor in there, and you do a bunch of biopsies, and you have one of those biopsies involved. That's probably would be a little bit different than the entire pit of the plum being involved. You know, you'll probably hit it multiple times. So if you have more than 2 cores, that means there's more than maybe one tiny little tumor. You may want to consider treatment like surgery. And the same thing, if any more, each core is about the size of a needle. So if you have more than 50% or half of that needle involved with tumor, it means that that tumor is a little bigger than just a tiny little whiff of tumor. So generally, again, generalization, these are the patients whom we might say you should consider a curative option if we think you're going to live 10 years and you want treatment, who might want to consider surgery. So if we actively surveil, we say, all right, you have a low-grade prostate cancer. You have a Gleason 3, 3 plus 3, or 6 tumor. Let's watch you. What are the chances that you're going to need treatment? So certainly about 30% to 30 to 50% of people within 5 years will have a little bit worse tumor. That means they'll go to a 4, they'll have a higher volume tumor, they'll get anxious, and they say, I just want treatment. So about 30 to 50% within 5 years will need treatment. Does that mean they're not going to be cured anymore? No, not necessarily. There is some data out of Canada, and Dr. Patel referenced this from Lori Klotz, who essentially said on their patients on active surveillance who ultimately went on to get surgery because they thought they needed it or their biopsies showed it, about almost 2 out of 3 had disease that was starting to grow outside the prostate. So active surveillance in and of itself, when you look backwards, is not always the most perfect option for everybody. Again, it doesn't mean you can't be cured, but there are some benefits to early treatment because you're catching it at an earlier stage of the disease process. So does surgery help? So again, a busy slide. So this is a study out of Europe. This could never be done here, where they diagnosed men with prostate cancer that they did not think had spread, and they randomized them because they agreed to be a part of a study to say, I'm going to treat you with surgery versus I'm going to do nothing. And they did find in this study, with quite a long follow-up, that the men who got prostate cancer surgery were less likely to have spread of their tumor and were less likely to die of their disease. So there is data. Now, it took a long time to get to that conclusion because prostate cancer, as you guys probably generally all know, is relatively slow growing. Now, again, not everybody, but if you take everybody, mostly it's slow growing. And they found that the number needed to treat, that means the number they needed to operate on to help, was 8. So you could say that's good or bad, but that's, I think that's a fairly acceptable number. And for younger men, so men in their 50s or whatnot, the number needed to treat to prevent a bad outcome was 4. So radical prostatectomy has been performed for a long time. I believe this study, I did not go pull up the 1866 paper, was done in Germany, and they showed and they described radical prostatectomy. And this paper, I believe out of Hopkins in 1905, demonstrated that it could be done in a subset of patients who had prostate cancer. So what is our goal as a surgeon? What is the goal as a cancer surgeon? Is to remove the cancer and try and leave the good stuff behind. And it's not easy in prostate cancer, and I'll go over that a little bit. In my opinion, and luckily I think my colleagues' opinions here, radical prostatectomy is likely the gold standard by which I think most other treatments should be measured. If I was with some radiation oncologists, I'm sure they would disagree, but that's okay, because you're taking the cancer out. It makes it a little bit simpler, and I'll go over that in a little bit. Hormone treatments, as you guys may know, prostate cancer likes testosterone. So if you take away a man's testosterone through either surgery or chemically, a lot of the prostate cancer will die. But I describe it as like spraying a room full of bugs. And you kill a lot of the bugs, but some of them don't care. And then eventually they'll start to grow, and then men get in trouble. So prostate cancer hormone treatment, while it can prolong survival in a lot of men, it is generally not curative if a man's going to live a long time for non-prostate cancer-related reasons. Radiation is effective. I'm not here to say radiation is not an effective form of treatment, and the data wouldn't support me saying that. But the gland is not removed, so I do think old cancers can resurface and new ones can show up because the prostate is still left there. Again, especially if you're young. So hopefully this will be as graphic as I get. And so here we go. This is an image of a man's anatomy. If you kind of just look on the inside, just in the middle. Your bladder is here. Your prostate is this little annoying organ that causes all the grief. And your urine has to travel through your prostate to come out. That's why men have trouble when they get older. This prostate starts blocking, that's why men get up at night to pee. Their streams are slow. This is the organ in trouble, that causes the trouble. If you look at it, it's a very small organ. And what is it surrounded by? The bladder's on top. You don't want to damage that. The sphincter muscle, meaning the muscle that women have to control the urine, men have the prostate to help control the urine, is right below it, attached to it. The bone is here, the rectum is here. There's a lot of stuff around the prostate that we don't want to damage, annoy, because it can cause problems. It is a tough surgery, it is a tough operation, and it's something that you need experience with. So really, before 1980, and this was Dr. Walsh kind of pioneered He's a very well-known urologist, in fact, probably one of the most well-known urologists out of Johns Hopkins, who kind of pioneered the current radical prostatectomy, how we currently do surgery. And it's a very interesting story. What he actually was doing, he was at a conference, and I can't remember where he said it was. And he was walking around, he saw this gentleman sitting on a bench. And he and his wife walked to this gentleman and said, oh, let's go invite that gentleman to have dinner. And his wife looked at him like he was crazy. Like, why would we go up to a random stranger and invite him to dinner? But sure enough, they did. What it turned out is Dr. Donker was an anatomist. And he asked, Dr. Walsh asked Dr. Donker, prior to this time, every man who got a prostatectomy was impotent. Because they thought the nerves ran through the prostate. So if you took it out, a man would suffer impotence. He asked Dr. Donker, where are the nerves? And Dr. Donker said, I don't know. They probably run through the prostate. So they went and they did dissections of cadavers. And after a period of time, he found that the nerves don't necessarily run through the prostate. They run behind it. So he pioneered the open radical prostatectomy. And since that time, we've all kind of tried to emulate him and the principles that he's tried to establish, and really did a really nice job towards making the operation, which was problematic and difficult, to a better one for all of us. What's the benefit of going through the belly? There's different ways you can do it. You can go underneath the scrotum. You can go through the belly. The benefits of going this way is you can get to the prostate. We as surgeons are familiar with that. You get good at what you're used to. The rectum, remember I showed you the rectum is right underneath, and you kind of have to peel it off. There's less of a risk of injuring that. You don't want to do that. And if you choose to do it, you can remove lymph nodes. Lymph nodes are where prostate cancer can go to first, and you get an opportunity to remove them to see if they're involved. So about in the 2000s, everybody has heard, I'm sure, of laparoscopic surgery where you go in with the cameras and the telescopes. Laparoscopic prostatectomy was done. And what the benefit of one of the downsides of prostate surgery is you can lose a lot of blood. There's a lot of veins in this tight space. And when you have it exposed to the air, the veins bleed. You can lose a lot of blood. And the risk of needing a blood transfusion is not insignificant. So what laparoscopic surgery does is you inflate the belly with carbon dioxide, and you hold pressure on those veins so you don't lose as much blood. The problem with laparoscopic surgery, and I've done quite a few of them, is that it's not very ergonomically easy for the surgeon. It's hard to get around. You have to go around curves. I was trying to fix my sink the other day, and something was in the way. And it's like you're trying to bend a corner, and it's hard to do because you're working with these instruments that are just two-dimensional. So if you're trying to sew with a stick or trying to move around, it's very difficult to do. But the benefit of it is, if you got good at it, you could do well. You could lose less blood. You could have a slightly smaller incision. But it was a very difficult thing to do. One of the advantages, the advantage of prostatectomy is that it can provide good staging information. That means with a biopsy, you can miss certain things. When the prostate is out, you don't miss anything. You know exactly how much tumor there is, where it was growing, is it starting to grow through like kind of the peel of the prostate or the capsule, and you can remove the lymph nodes. Most times, the postoperative course is smooth, although any surgery does have risks. It's generally a one-day treatment, so often radiation will be coming in for 6 weeks once a day. It's a one-day treatment. Failure after surgery, this is one of the main benefits of surgery, is that failure, that means if it didn't work, it's pretty easy. Your PSA should be 0 or very close to 0 if the prostate is out. So failure is easily identifiable if you've had radiation, for example. I've had patients, and we've all had patients, where you have little spikes up and it causes anxiety for us and it causes anxiety for the patient. It doesn't mean they've had prostate cancer come back, but it's a little bit easier after surgery. If the PSA starts to go up, there's something there. And radiation can be undertaken after surgery in a smaller dose than if you didn't remove the prostate. So robot surgery, I'm going to focus a lot about that because that's what probably a lot of people who've heard about surgery are now focused on. It was introduced in 2000 when Intuitive came out with the robot, and it has taken off. So since then, the majority of prostatectomies now, and I think there was about 140,000, 130 to 40,000 prostates done this year or last year. Majority of them are now done robotically. It uses the same principles of pneumoperitoneum, that means carbon dioxide and laparoscopic surgery, except you have this robot machine that we'll go over that helps us. But the learning curve, any surgery has a learning curve. That means you're going to be better when you do after your 100th one than after you've done your first one or your 5th one. So the problem is a lot of us or a lot of surgeons were good at open surgery, and now you are going to do a completely different technique, and it takes time to get good at it. So I personally think if you're going to say, well, the most important thing is how good is your surgeon at doing your procedure, whether it's a laparoscopic, open, or robotic procedure. I venture to say most of us now are probably pretty good at robotic surgery because that's what the patients want. That's what Intuitive has kind of marketed heavily, and we're now pretty good at it. The length of stay, I think, is a little bit shorter, and I've done a lot of both. I was lucky to be in the training era where we did a lot of open surgery and kind of transitioned. But I do think the length of stay is a little bit shorter. You definitely lose less blood. So the chance of you needing a blood transfusion is less. But I think most people would agree, again, you'll get different viewpoints depending upon what you'd like to say in your paper, is that most people do equally well in the hands of an experienced surgeon who knows how to do the procedure well. So same thing. You guys have seen this slide before. We want to take this thing out and spare everything else. So going into a little bit more anatomy, again, this is now we're laying down. And behind the prostate, which is right here, it's socked in there. The muscle is here, and you got to preserve that muscle because if the prostate is gone, that's kind of the clog in the drain. If you take the clog in the drain out, all you have is a muscle. So you got to preserve that muscle and not injure it because you have to strengthen that to regain the urine control. Up here is the bladder. Down here is the rectum. And again, this is a little bit more anatomic view of it. Everything is very close. These yellow things running behind the prostate, right above the rectum, are the nerves. These are the things that we didn't know where they were before Walsh and Dunker described where they were. We thought they were going straight through the prostate, and so everybody's going to be impotent. The reason is that 1 or 2 millimeters here, we took it with us, and it wasn't until we realized that that's where the nerves were that men had started to have better results after surgery. This is an open prostatectomy. So if you're going to make an incision, usually from the belly button down, actually now surgeons are getting a little bit better. They'll make it a little bit smaller. And this is the goals of the surgery. You go in, you find the prostate, which is right here, and then you preserve this thing called the urethra or the sphincter. That's what you need to preserve. If you injure that, burn it, things like that, you can suffer from incontinence, which is a risk after surgery, but most men do actually very well. You guys have heard of Kegel exercises. Kegel exercises, as I'm sure women have heard it, after they have children, they have to do these exercises to strengthen the muscles to get their incontinence better. When men remove their prostate, because your friend the prostate is causing a blockage, all that's left is the muscle. So you have to preserve that muscle so you don't suffer from incontinence, or you regain your continence. The next thing you do is these little things called the neurovascular bundles are the nerves for erections. And so what you try and do is you try and peel these nerves away from the prostate and save them so that men can regain erectile function. Doesn't always work, but that's the goal of the operation if you feel it's safe to do from a cancer standpoint. Then I'm not going to belabor this point. You essentially then you go for, here's the muscle, here's the bladder, and you separate the bladder from the prostate. The bladder from the prostate. And then what you do is you sew the bladder back down to that opening. So it's pretty simple. I mean, globally, bladder's up here, prostate's in the middle, and the urethra is here. You take out the middleman and you sew it back together. The catheter is left in through the penis for about 7 to 10 days. You can't take it out sooner. There's a higher risk of problems not being able to pee. Similar patient selection in open prostatectomy. Most people would try to operate on patients who don't have disease outside the prostate. Again, that is a little bit debatable. I think hopefully the field will change a little bit in that standpoint. Robot prostatectomy, you get into the belly. So when you do open surgery, you kind of stay out of the cavity where you get into your intestines. With robot prostatectomy, most people would go up higher. You do get into that cavity. So if you've had a ton of surgery before, let's say inflammation, scar tissue in the belly, you might want to consider having an open prostatectomy just to avoid all that scar because that can cause some misery for the surgeon. This is what the robot looks like. So sorry, it's not the best quality, but essentially the surgeon sits at a console. there's a bedside assistant, and this is where the patient is, and you insert the instruments. And what happens is, and the surgeon controls these instruments through his or her movements done at the console. Obviously, this is the problem. The surgeon has to scrub out and go back in, or when you're taking the prostate out, the surgeon will scrub in and take out the prostate. So what makes the robot work? You have these little instruments on your hand, these little keypads where you essentially, this is what it looks like, and you put your hands in, and what happens with the scissors or the instrument that you're using, the robot does what you want it to do. So if you move your wrist this way, the robot will move this way. So if you go like this, the scissors will work. So this really revolutionized treatment because you can make those corners, you can do sewing much more easily than you could with the laparoscopic, meaning that little stick where you only had in and out and turning. So this really made the surgery much more feasible and less challenging physically for the surgeon to do. This is what it looks like. Instead of one long incision, you have a bunch of these laparoscopic instruments, depends on what you're comfortable with. I think I put in 1, 2, 3, 4, 5, and then a suction port up here. So about 6 small instrument ports here. And then once the instruments are put in, and then you dock the robot, and then you let the robot do what you want it to do. Benefits of robot surgery, you lose less blood. Once you get good at it, I think it's quite good. Now, I've done a lot of open, I've done a lot of robots. I like doing robotic surgery because you get good magnification, you lose less blood, and it's challenging sometimes when you're doing open surgery. You can get closer to the field. So if you've asked me what would I prefer to do and someone in whom I can do both, I prefer to do robotic surgery because I'm much better at it than I was 10 years ago when I first started. This is the learning curve. What learning curve means is that it's significant. That means it's a tough operation. You don't really get good at it until you've done a lot of them. So I think one of the most important things is, and you guys probably, and this is well out there, you need to be comfortable with the surgeon. The surgeon needs to be comfortable with what they're doing. I'm sure that's been a question that you go, I'll ask, how many have you done? Everybody gets asked that. What's interesting is that most patients aren't trained, actually interestingly, most trainees are probably not very good now at open surgery. Everything is so robotic heavy that open surgery is kind of going by the wayside. So there are surgeons who still do that. And there are certain scenarios where it's probably appropriate. Oops. So what are the downsides of surgery? So most people eat the next day, most people go home the next day. Again, any surgery has problems, potentially, heart problems, lung problems, and bleeding problems, infection problems, but most people do quite well. The catheter stays in 1 week. So what's the problem with surgery? What's the problem with treatment? Why is there such a big deal? If prostate cancer treatment had no problems in terms of treatment, then we wouldn't worry about subjecting men to side effects. So we call it the trifecta. The trifecta means everybody is, well, it's pretty predictable. Most people who want to have surgery or want to have treatment want what? They want their cancer gone, number one. That's the thing that they're focused on first. Okay, now I think we do pretty good with that with surgery. The second thing people want is to regain their urine control. Nobody wants to be wet. That's why that muscle is important. And the third thing they want is their erectile function. Now, everybody's a little bit different, but for the most part, I think most people think along that way. But once you get number 1, then you get number 2, you still want number 3. Again, everybody's a little bit different. But I do have to say, Kegel exercises, the strength of that muscle is very important. Doing it well. And most men, I would say 95% of men are happy with their urine control. They might drip a couple of drops when you're lifting something heavy, sneezing, but most men are happy without pads. Erectile function is highly variable. So if you're going to ask me, and this is what I tell my patients, what's the biggest downside associated with treatment, and specifically surgery, although it's not just related to surgery, it can be with radiation as well. Erectile function does suffer. So it depends on who's doing it, how good the function was before. A lot of the patients will think, oh, well, my erections are so-so. It's going to be better after surgery because the cancer is taken out. It doesn't work that way. If it's not so good beforehand, it's not going to be good afterwards. So the people who have the best results as far as erectile function are the people who are younger and have good function. And I think you need to know what you're getting into. But again, everybody has different goals. So you have to understand what those goals are before subjecting someone to something. We do pretty well. So if we can get it before the cancer has left, 80 to 90% of people remain disease-free. If it's starting to grow outside the peel of the prostate or peel of the plum, we still do pretty well. And then those patients can be salvaged with radiation. So you can do radiation after surgery much more easily than doing surgery after radiation. So what if you chose to get radiation and it fails? I think this is one of the things that people oftentimes don't understand when they get radiation when they're very young, and they get it when they're 50, and then they have a failure when they're 62 or 63. It's very difficult to do surgery after radiation. We do it. It's called salvage prostatectomy. It causes a lot of there's a lot of scarring from the radiation. Again, not everybody needs a salvage prostatectomy. In fact, most men don't. But if you do, it's not a fun operation for us as a surgeon, and it takes a long time to recover, and the complications are much higher than if you were to do it at the onset. Because of that scar tissue, that muscle, there's a significantly higher risk of incontinence, definitely a significantly higher risk of erectile dysfunction, and I think healing, meaning you sew that urine channel back down to the bladder, that healing process takes a lot longer. And I certainly have had my fair share of problems in dealing with these healing problems. You can get the patients through it, but it can be a little bit of a struggle. So in conclusion, radical prostatectomy is a very effective treatment for prostate cancer. And in fact, I would say it's probably the gold standard of treatment because you're taking the cancer out and it doesn't burn any bridges relative to any future treatment. It offers a treatment which is meant to be curative for the most part and for most men. I think it offers the best staging information, no question, because one of the reasons is you're biopsying something. About a third of men have cancer that's a little bit more aggressive than when you take it out than what the biopsy shows. So it really gives you good staging information. You know how much cancer there was, you know what Gleason score it was and where it was going. And most patients with local failures can be salvaged. That means they can be effectively treated with additional treatment. I think both open and robotic prostatectomy are excellent operations if it's done in the right hands and it's done with a person who knows how to do each operation. Although I will say most prostatectomies, including done in my hands, and I'm sure with my esteemed colleagues here, are done with robotic assistance. Oncologic efficacy, meaning cancer efficacy, is excellent. Urinary continence is excellent. Erection function can be good, but I think that's the thing that suffers the most. But I say to the patients, we can help you, but it may require just a little bit more than what it used to be. So thank you very much. I really appreciate the opportunity to be here, and I look forward to your questions later.